My name is Richard Molarski, and I'm here with Lizzie Hansen and Michael Leo for the palliative care within the context of interdisciplinary ICU care, exploring the nursing-specific contributions, and this is our yearly report. So following the structure that our WJ asked for, the issue is that many people die in the ICU, and prior studies suggest that some aspects of palliative care, for instance, symptom management, is often inadequate, and we don't really understand the contribution of nurses to the quality of palliative care or the relationship between the quality of that care and important patient or family outcomes. So, as we presented last year, our study has 4 aims. The first 2 we presented last year, which was operationalizing our measure set. This year, we're enrolling subjects, ICU patients and their families, at 2 intensive care units and assessing the relationship between the care delivered by measuring the quality of care with the operationalized 14-item palliative care quality measure set. And then we're measuring both a nurse report of their contribution as well as their self-report of the quality of care delivered on those 14 specific items, and an outcome measure, the family member satisfaction as measured with the FSICU. We'll be triangulating then between these 3 different measures to assess the relationships. Our methods we summarized last year for the Delphi panel. This year, again, it's really just prospectively enrolling patients and their families and applying these 4 different measures of quality or satisfaction report. At this point, I'll turn it over to Lizzie to tell you about our audience.
So our audience is really the practitioners in the ICU, but also the leadership in the ICU to really increase the palliative care provided to patients who are critically ill earlier on in their stay in the ICU. We also envision that researchers and quality measure developed among the audience as well as patients and their families themselves. And as you'll see later, we have had a great response rate from family members in this study so far. We plan really to publish at least 3 peer-reviewed articles, and in addition to what we have done so far, presenting primarily abstracts, we also plan to be part of the Palliative Care Conference Series, which is presentation once a month that's taking place here in Portland, as well as the Palliative Care and Keeneman's statewide annual conferences. We also nationally plan and have already, Dr. Richard last year presented the Delphi panel at the American College of Chest Physicians at their conference. And Dr. Grover, who is a fellow, has submitted an abstract that we hope will be accepted and presented later this year. We also presented the survey we developed specific for nurses at the Western Institute of Nursing Research Conference. So as Richard said, we have done phase 1, and we are really waiting to test the measures so we'll be able to start the publications. We have done most of the recruitment, and the response rate we have received is from 91 to 98%. We have completed Site 1 and have done at least 30% at Site 2, and as we mentioned, there will be 150 patients, 150 families, and approximately 150 nurses participating in the study. We'll talk in this presentation about our measures as well as the instrument or the tool that we developed for the nurses. And if we have the time, we'll touch on what Dr. Grover did as part of his fellowship with shared decision making. And we are planning to do within the next 2 months the triangulation of the measures, so we will be able to complete our findings in the study. And these are the operationalized set of the quality measures that we did last year, and we presented in great detail on the Delphi panel last year. So this is really just a reminder, and I will pass this on to Michael for the next slide, please.
All right, so in this slide, what we have are the 14 items presented previously, grouped into 6 domains that were found to be relevant based on prior work funded through the Robert Wood Johnson End-of-Life Care Work Group. So the 6 domains are patient and family-centered decision-making, communication within the team and with patients and family, continuity of care, emotional and practical support for patients and family, symptom management and comfort care, and spiritual support for patients and family. What we have presented here are the means and standard deviations for the 75 participants we've gathered at one site. And not surprisingly, the highest rated dimension was symptom management and comfort care, which was also found in previous work to be the dimension rated the highest with 91.9%, and the lowest with only 2.7% is the spiritual support for patients and families. Notice too that the other dimensions hover between 28.9% and 55.6%. Not very high numbers at all. In this next graph, we present the demographic characteristics for the 75 participants gathered at the first site, and consistent with the demographic profile of our region, the great majority are white, and of the patients, 37.3% were female. The average patient age was 60.1, and the average age of the participating family member was 53.11 years. Not surprisingly, because a lot of the family members were children of the patient. The average length of the stay in the ICU was 7.5 days. And this next slide presents the results from an instrument developed by the Robert Wood Johnson End-of-Life Care Work Group in previous studies. And this is titled the Bedside Nurse Survey. And what it asks for is nurses' perceptions on the quality domains, which were based on 54 items grouped under how often a certain procedure was delivered and the quality of that care. And consistent with the findings in the chart review, the highest rated dimension was symptom management and comfort care. And you'll notice that the other dimensions were lower than this particular dimension, but much higher than what was presented in the chart reviews. Also note that there are greater than 6 domains in this survey. The additional domain of emotional organizational support was not part of the chart abstraction, and they also had continuity of care and communication divided between team and patients and family members and colleagues and caregivers. This slide presents the actual total scores for each of the measures presented previously. So the average reported quality score for the survey, the bedside nurse survey, was 73%. The average for the total measured quality delivered based on the 14 quality measures was 49.5%. And the FSICU, which is a measure of family satisfaction, was rated at 85.7%. You'll note here that the actual delivered care was much lower than what nurses perceive and what families perceive, with families perceiving the highest. The next 2 scores, which are broken out into dimensions in the next slide, reflect a measure developed for this study, which also asks for nurses' perceptions on those 14 quality indicators on the percent effort exerted and the quality of care. And then below, what I have presented are the distributions of these total scores for the 75 participants sampled at Site 1. And as you can see, they're all relatively normally distributed, with probably the exception of family satisfaction, which is slightly negatively skewed. Okay, with that, I will turn it back over to Lisi.
So this is the survey we developed to actually quantify nurses' perception of the care they provide in the 14 quality palliative care indicators, and they are also then divided into the 6 domains. And we asked nurses, as I mentioned, both to quantify how much of the care they did was in the domain of nursing, and also the quality care as they saw it. And interesting enough, nurses rated, compared to the chart reviews, their effort and quality higher, and notice also spirituality support for patients and families much higher by the word of the nurses compared to the medical chart extraction. So we talked briefly about the presentations we have done and are planning to do the papers. We are on time, so we will be doing the analysis at the end of August. We really hope to work with quality measure and reporting groups on these measures, as well as Robert Wood Johnson, so we could maybe submit them to the National Quality Forum and provide input and maybe expertise due to the work we have done so far. And I will now pass it over to Richard.
Yeah, so just to comment again on this slide, one, we really want to express our gratitude for Robert Wood Johnson and funding this work, and we think that we've been successful in our project and are looking forward to completing our Site 2 studies and these analyses, especially for those last 2 bullet items. Serving on the AMA PCPI, they're always interested in field experience, and I think once we have our measure set and are able to analyze its performance, some of that information will be useful to quality measures that already exist, as well as potentially working with others at this meeting to discuss whether this set is reasonable to submit to NQF for a future measure set. So with that, I'm just going to briefly summarize, as our time is limited, some of the results from Dr. Grover on the next 2 slides. Dr. Grover came to us and wanted to work and help our project, and was very helpful in much of the recruiting and day-to-day work, but was also interested in the aspect of shared decision-making. So working with one of our consultants, Randy Curtis, we developed 4 extra items that were developed in a way to be parallel to the FSICU, and surveyed 50 families at the time of this interim analysis anyway, to see how they rated and what they thought about the shared decision-making that was part of the care that they received in the ICU. So very briefly on the next slide, 47 of these folks filled out the questionnaire with an age that's similar to our other demographics. The 4 questions are really these. How well did doctors try to understand the ways that you wanted to be involved in medical decisions? And you can see they generally rated that quite well. How well did the doctors work with you in the ways that you wanted to be? Again, rated quite well. How well did doctors try to understand your values and preferences? A little bit lower, but again, fairly highly rated and a similar distribution. And lastly, did you feel that those values and styles of communication were respected? Again, averages in the 66% range, excellent. So although this preliminary analysis did not find any association with any of the demographic characteristics or the overall FSICU, it is some great preliminary work, and we are happy to have been able to add a sub-study to the work that we did in these 2 years. So with that, we'll conclude our presentation and open it up to discussion.